Hi, this is Jack Wheeler, lead instructor for Nursing 255 at Contra Costa College, and this is our suicide assessment lecture. My hope is this lecture, along with your suicide assessment techniques skills lab that we will do, where we will practice the actual questioning techniques of Sean Christopher Shea. My hope is that you will, whatever setting you end up working as a registered nurse in your career, you will be one of the leaders in the ability to assess for suicide. All right, you will notice in the reading it does contain a significant portion of the reading on this is on borderline personality disorder. And we'll talk about that in detail in this lecture. We also have a personality disorders lecture that will be toward the end of the course, but what I've found is we can't really talk about suicide assessment and how to approach that without talking about borderline personality, because patients with that disorder move in and out of suicidal feelings very easily. So we have to take that into account. Um, and there's a different way to approach it, which we'll talk about in detail later on in this presentation. All right, so our objectives for this lecture, compare and contrast suicidal behavior versus suicidal ideation and self-harm, self-mutilation, risk factors, protective factors, protecting yourself legally, suicide assessment in other settings, the strengths and limitations of using a suicide rating scale, and how a no harm contract, you'll frequently see in charting, they'll say patient contracted no self-harm. You might even see just the initials CNSH, which means contracts for no self-harm. So it might be a patient that has some what we call passive suicidal feelings, but they agree they'll be safe on the unit. All right, so more objectives. So how suicide is different with the suicide assessment is different with a patient with borderline personality disorder. Special considerations with a psychotic patient around suicide. The 3 biological treatments that have been shown to reduce suicidal feelings. 6 common medications that can actually increase suicidal feelings, which surprisingly a couple of them are a few of our common antidepressants, the category known as selective serotonin reuptake inhibitors, along with Strattera, one of our very common ADHD medications, and Dilantin, an very popular anti-seizure medication. So those medications can actually increase suicidal feelings. We'll talk about legal liability, and there's 3 categories when a patient suicides, and we'll talk about how to keep yourself safe legally in the future. And then, well, there's going to be a time when we're discussing why the suicide rate between Persian Gulf military veterans in one significant research study that's become famous, they were expecting to see more suicide in combat veterans versus people that were in the military that didn't see combat. And what we'll discuss later on is that there wasn't a difference. There wasn't a statistically significant difference between people that had seen combat and people that were in the military but didn't see combat. So we'll talk about the conclusion about why that happened that way. All right, so some common definitions. Suicide ideation, that just means thoughts about killing yourself, and that can be chronic. Suicidal behavior is actual behavior, taking an action that can that can actually lead to the end of your life. And so we're not looking at the adolescent that cuts themselves several times all over their body, especially the forearm. It's usually the forearm of their non-dominant hand. So since most people are right-handed, you see it a lot on the left forearm. You see it a lot on the hips, especially in girls, on the thighs, on the abdomen. And suicide is the leading cause of death in postpartum women, which is a little bit of a misleading statistic because postpartum women generally they don't take a lot of risk, and so they don't have a lot of accidental deaths, and they're postpartum, they're young, they're childbearing age, obviously, and so the kind of emotion, the hormones that are released in the postpartum state is one of the higher risk factors for women in that situation. All right, so just demographic risk factors. What we mean by demographic are just categories of where you are in the society. And so males, they tend to have more completed suicides than females, where females make more suicide attempts. And this is because men tend to do a more violent attempt when they do it. They do it more with hanging, more with shooting themselves, and these are more lethal than the more common female ways of doing it by, cutting or an overdose of pills. And the reason why the cutting and overdose of pills is less lethal is because there's more time to be rescued, more time to reach out and send goodbyes to people, and then the people kind of rally and get you help. That doesn't really happen when you shoot yourself or with hanging. So other demographic risk factors being Caucasian, followed by Native American, and then in the transgender or gay, gay, lesbian, queer, Q plus, hopefully I'm not leaving any of them out. That population has a much higher risk for suicide, especially with teenagers. And you'll remember from our childhood lecture that teenagers that feel like they're not going to be accepted by either their parents or their culture because they're gay or transgender or bisexual are at an especially high risk for attempting suicide and completing suicide. So that's a very high risk category. But one thing to remember with demographic risk factors is that you'll see some people that you would think they would be suicidal because they hit all of these demographic risk factors, but they're not. You'll see some homeless people. You would think, why in the world is this person not suicidal? They might have chronic pain, they might have addiction, they might have tons of our risk factors, but and be Caucasian or Native American and gay, and all of that on top of each other, and they're still not suicidal. So that's one of the limitations of just looking at demographic risk factors, but they are just something to keep in mind. Okay, risk and protective factors, and I include these kind of slides just because I know some of you are very visual learners. I'm not going to go over these one by one, but when you look at them, you can see, and it's important when you're assessing a patient for suicide that you don't just look at the risk factors, you also look at the protective factors. Some people's protective factors are very strong. If they have just looking at them up there, if they feel connected to anyone, to their families, they feel part of a community. If they, the first one here, restrictions of lethal means of suicide. So in other words, if they're in a country where there's not a lot of firearms, probably any other country besides the United States, at least comparatively, then that makes it less of a risk. If they have a firearm in the household, that makes it more of a risk. And so, let's see, some of these other ones, if they have care after they're hospitalized, so if somebody goes into the hospital, if they're able to have follow-up treatment, um, if they don't feel like it's moral to kill themselves, that's. And then when you look at the risk factors, some of the ones that stand out to me: substance abuse. There are people that you'll meet if you work in psych or in the emergency room who are only suicidal when they're intoxicated. And so alcohol abuse, in anything, meth, methamphetamine, the drugs that cause you to be impulsive, those are very dangerous. Mental illness, especially like a first break, psychotic break with somebody with schizophrenia, or somebody that suffers from severe depression or bipolar disorder, and especially bipolar disorder where they have a mixed episode. Somebody in a domestic violence situation, and family history of suicide is a very big one, especially if parents have attempted suicide or completed suicide, especially. And those of you that are parents, you know that your children, they don't do what you tell them to do. They kind of follow your example with things in life. And so that's a conversation I've had with parents a lot when they've made a suicide attempt. That people will convince themselves that everybody be better off without me. My kids would be better off without me. I'm a drag on everyone. But when you give them, you can kind of wake them up a little bit and say, hey, the research shows that if you show your child that when you had a tough time in your life, that you responded by giving up, by killing yourself, then you've just kind of set that example. Kids, they watch how you handle tough times in your life. And so, whether you like it or not, you never stop being a role model for your kids. If they're in your life, you're a role model whether you want to be or not, and you can't take a day off. That's hard. All right, so, okay, let's move past this. Okay, so like we said, mood disorders, psychotic disorders, panic disorder is one of the ones where people are just very uncomfortable day to day. And then a recent onset of an illness that's a serious illness. This brings to mind when Robin Williams, the comedian, he was diagnosed with Lewy body dementia, and you can imagine if your whole success in your life and your whole self-concept was around your wit and your ability to make people laugh, that being diagnosed with dementia would be devastating. It's devastating to anyone, but especially someone who's in that kind of life. And so, and then the Lewy body dementia, it makes people more impulsive and more likely to do a violent thing. And killing yourself really is a violent thing, especially by hanging, which is what Robin Williams did. All right, key symptoms. So anhedonia, that's the ability to, you can go do the things that normally you would do to make yourself feel better, and you don't feel better. And that makes you feel much worse to know that even when you're, like if you're somebody that likes to go to the beach, you go to the beach and now you're just depressed at the beach. And so it's very frustrating. Then some other key symptoms: hopelessness, and then we talked about panic disorder and just anxiety, not being able to sleep. Sometimes people will get an illness that comes on, or I think I knew somebody that had fibromyalgia, and became suicidal because it was interfering with her sleep. And somebody that had never been hospitalized before, never been hospitalized since that I'm aware of, that became suicidal just because they couldn't sleep. And then we have command auditory hallucinations, and you'll see that abbreviated as CAH in charting notes by psych professionals. And what this is somebody that's actually hearing a voice telling them to kill themselves. And so, some of the obvious things you always, when you have a patient that's hearing voices, you always want to ask them, what is the voice telling you to do? And then a follow-up question to that, if the voice is telling them to kill themselves, do you feel like you have to do what the voice is telling you to do? And that can vary greatly between patients. If they think the voice is, say, the voice of God, and they have to follow it, that's much more worrisome than the patient that says, no, it's just like an annoying, like a little kid giving me a hard time, just, so I ignore it, I go distract myself, but, I'm not going to do that. Just, I don't feel like I have to do that. And so that's a very important differential, part of your assessment. If you have somebody with command auditory hallucinations, do you feel like you have to do what they're telling you to do? Very important. All right, so other risk factors, suicidal behavior, a history of prior suicide attempts is the biggest one. Remember, anything that someone has done, just a principle in psychology, if somebody has a history of doing anything that's very significant, then the possibility that they'll do it again is much higher than somebody that's never done it. And so the examples, some other examples apart from this topic, if somebody's been violent, if somebody has gotten a divorce, some of the statistics that came out in the 80s were, if you get divorced once in your life, your next marriage, it's more than 50% likely you'll get divorced from that marriage. And so, that didn't mean that you shouldn't, that marriages are bound to fail. It just means that if you do something drastic, like, like getting a divorce is kind of a drastic thing, then you're more likely to do it again if you've done it in the past. That's just a general principle of human behavior. So the other things we look for are aborted suicide attempts or in, putting their life in danger on purpose, which some people do to kind of feel alive, but also other people do because they're actually trying to get themselves trying to end their life. And so, like I spoke about earlier, just having access to firearms, that research that I had mentioned earlier, that the people that saw combat in the first Persian Gulf War had the same rate of suicide as people that didn't see combat. So that was one of those things that in research, that was not the expected finding. The expected finding was that you would think that people that have seen combat, and you assume people in combat have trauma, and that regardless of what kind of soldier you are, there's always a coming out of combat. That's a significant event that you would think would put somebody more at risk for attempting suicide, but that was not what this research found, and that the determining factor was they decided that they thought it was because when you're in the military, you go through extensive training in how to handle a firearm. There's if you watch some classic military training or military movies that show their boot camp, their training camp, it shows how they're taught how to value their weapon. Not taking care of their weapon can cost them their life. And there some of the chants, my weapon without me is useless, and me without my weapon is useless, and all those kind of things. They reinforce um, the importance of a firearm to a soldier. And so most of the time, people that have been in the military own a firearm. All right, family history. So any family history of suicide, especially parents, but anyone in the family, the closer the family member, the higher the risk, um, significantly increases someone's risk. And psychiatric diagnosis, when we say Axis 1, those are clinical syndromes. And um, Axis 1 the Axis system was done away with in the DSM-5. So I probably should take that out of the slide. But maybe I'll do that in the future. But anyway, you should know that people with a serious psychiatric illness are at a higher risk of suicide. All right, so stressors. So anything that leads to significant humiliation. Um, and this is, it can be social status, it can be the end of a relationship that's especially sudden and brutal. Somebody, you thought the relationship was going great, and suddenly they've broken off your long-term relationship. You've lost all your money suddenly, or like we talked about earlier, with a sudden change in your health status. So that's a big one. Um, just an example of a triggering event leading to humiliation. We had there was a patient one time who had a significant, kind of social role at his church, and he was a karate teacher, and it turned out he had kind of a flirtatious text message exchange with some teenage girls that were in his karate class. And he, eventually that was discovered by the girl's parents, and led to them calling the police and calling the church. And he became suicidal, because it was such a fall from his social standing as the Mr. Karate Man in the church. And now he's being looked at as a creep, and even though, as far as we know, there was no sexual contact or anything. It was just a little flirty thing. Um, I mean, bad judgment, definitely, but it was very overwhelming for him. He had taken a bottle of strong alcohol, I believe it was Jack Daniels, and a firearm, and drove off he was going to get very drunk, and shoot himself. Um, he texted a goodbye to his sons. He had two teenage sons, and they were able to get the police to trace his cell phone, and they found him before he shot himself. And so that was a very good example of this is somebody that hadn't ever been depressed or suicidal before, and this fall from social status in his life was just overwhelming, and he almost ended his life. So with him, I remember when I admitted him, he said he wouldn't do it now, that he didn't believe he felt like he realized he didn't want to do that to his sons, that he couldn't do that to his sons. But he was saying he was not suicidal anymore, but I still listed him as a high risk for suicide because he had so many of the risk factors. He had a firearm. He had obviously I don't think he was a regular heavy drinker of alcohol, but he had the potential to abuse alcohol. He had the recent humiliating event. He had all of these risk factors, and at least at the start, I listed him as a high risk for suicide. The other big thing here is like an ongoing medical illness where there's uncontrolled pain, and so that can make it hard to want to continue with your life when you're going through a lot of pain every day. And then some history of abuse or neglect, and then along with that comes sometimes you kind of internalize the psychological abuse from the person that's been abusing you. And then, like I mentioned earlier, some people are only suicidal when they're intoxicated. So it's another thing with alcohol abuse. Right. So protective factors. So some internal protective factors: just having an ability to cope with stress, having religious beliefs, especially religious beliefs where you believe, you know, that if you live a good life, you go to heaven. If you kill yourself, you go to hell, if you believe in that. Um, and religious beliefs that you're not allowed in your religion to kill yourself. And in your religion, it's a very dishonorable thing to do. So the ability to tolerate frustration, kind of similar to the ability to cope with stress, and not having psychosis. Remember, psychosis with people that have, especially their first psychotic break, if they're schizophrenic, or if they're having command auditory hallucinations telling them to kill themselves, that places them at a high risk for suicide. So not having psychosis is a protective factor. All right, so some other protective factors, also known as external, kind of outside yourself, a feeling of responsibility to someone else. So like if you have kids that are relying on you, but even pets. I've had patients before. I had a patient before who he wouldn't kill himself because he really loved his dog, and his dog was older. He knew that nobody wants to adopt a 10-year-old dog. And so he felt like his dog would not be okay if he killed himself. The way that can go a little bit sideways is that on another admission, he had decided to drown his dog before he killed himself, so that so they wouldn't have to worry about his dog not being okay. Don't worry though, the dog didn't. He wasn't able to drown his dog. He tried to, but wasn't able to. The dog got away. So having a connection, a positive therapeutic relationship. It doesn't have to be an outpatient therapist. That's ideal, but it can be just caregiver or even their outpatient internist, if that's somebody that they connect with, that they see every once in a while. That's really helpful. And then some kind of social support. Those are protective factors. All right, so we're gonna have a skills lab about how to ask about suicide, but just some basics here are specific, asking them specifically, what are your thoughts? Plans, do you have intent to act on these? A lot of people will have a suicide plan, but they don't have intent. They're not actually planning to act on that plan. It's kind of like a backup plan for in case everything goes wrong, but they're not thinking they're going to do it. It's not plan A, it's plan B or maybe even plan C. And so for their suicidal ideation, which are their thoughts about suicide, is it all the time? How intense is it? Sometimes for intensity, we'll ask them on a scale of 0 to 10. People can be chronically suicidal. Sometimes students will ask, how can they be discharging this patient? They're still saying they're suicidal. And the reason is some people are chronically suicidal and they're always suicidal, at least a little bit. And so that's why we want to ask them, like on a scale of 0 to 10, just like you would ask with the pain scale, 10 being your most suicidal ever or most suicidal you can ever imagine, and then 0 being not suicidal at all. Where would you say you are right now? How suicidal have you been in the past month versus, comparing that to the most suicidal you've ever been? All of those kind of things are just trying to get at, for the person that's chronically suicidal, is this really a crisis, or is this, they're just a little bit below their baseline? And then for the plan, is the plan lethal? Do they have all these details worked out? Have they rehearsed it, which we call preparatory acts? In other words, do they have like tied up a noose that they have hidden somewhere in their house? Do they have, like you see on the slide, medications that they're planning for an overdose? Is there, how lethal is their suicide attempt? Remember, the most lethal suicide attempts are shooting yourself and hanging yourself. So I would be more worried about the hidden noose than I would be about the hidden pills. I would still be worried about both, but the noose is the more lethal one. And then availability. I had a patient one time. She lived down in the little town right before you get to Santa Cruz. I forget what it's called, but right next to her house, there was a cliff. And, these fancy houses that live up in the hills, and, it's a beautiful view, and I'm sure a multi-million-dollar house. However, her thought, her plan was to jump off that cliff. And this was a very lethal plan and a very available plan because it's right next to her house. And so that was such a way to, you don't want to send her back home until she's kind of over that. She's not having that thought because of the availability is right there. Okay, so the behaviors, like we said before, if they've attempted in the past, what we mean by an aborted attempt, it means they're attempting, they're like taking a bunch of pills and then somebody comes home, so they stop, or they stop, they were going to hang themselves, but now they're not going to because somebody's home. They've kind of rehearsed it, like, loading a gun and playing a game called Russian roulette, where you put one bullet in the chamber, or not the chamber, the whatever you call the little thing that spins around, and you spin it, and without looking, you pull the trigger, knowing that you have there's a 1 in 6 chance it'll shoot you. And so so those are more scary than people that just cut on themselves to get like a little stress relief. So those behaviors, and then like we talked about before, the intent. Do they really expect that this is going to happen? And this is where you want to look at, do they have a focus on the future? Can they, when you ask them questions about a couple of years from now, do they have an idea about it, or they're not really thinking about it because they really do expect to be dead by then? Okay. And then most of the time when people come in for treatment, the reason why they do is because they're ambivalent. They, people that are 100% sure they want to die, they generally do succeed in killing themselves. They don't go for help. But that little part inside of them that that doesn't want to kill themselves, and it might be 95% they want to die and 5% they don't want to die. That little 5%, that's where our tricky little questions that I'm going to teach you that are from Sean Christopher Shea, those are what we try to kind of tap into, that ambivalence, that little 5% that doesn't want to die. It can be more, but it can be as little as 5%. And then, you can explore that. Why do they want to die, and why wouldn't they want to die? So another tragedy that we look at here is where there's a murder-suicide. Some very disturbing situations. You sometimes will have especially with somebody postpartum that is going through a postpartum depression or psychosis, especially for a first baby. The person is, a lot of times we don't do a real good job of training women what to expect when you have a baby. And when you have a baby, especially for the female, it's like suddenly you're not just you in the world anymore. You're have this obligation that's going to be with you for years and years, for 18, 20 years. And so that can be overwhelming, and that can lead to some people becoming homicidal. And our other big issues where there's a murder-suicide is when there's domestic violence involved, or when there's somebody has in their relationship they're having an outside affair, and that gets discovered. Sometimes people that would never be homicidal can be homicidal when their mate is having an affair with someone else. And so these are very dangerous situations that can lead to a murder-suicide kind of tragedy. All right, so some clues that we worry about. The person is suddenly that was very upset, very troubled. Suddenly they're relieved, and the concern with that is that they've made the decision to kill themselves. And so the behaviors you might see is they're gonna give away things that normally would be very valuable to them. They might reach out to, their parents or their children or people they've had a falling out with to kind of repair the relationship before killing themselves. Saying goodbye, sending a goodbye note. And sometimes the note doesn't say goodbye because they don't want to be stopped. It'll say, I just want you to know how much I appreciate you. One of the things to know as a nurse is patients, they generally don't appreciate us that much. If you got into nursing to be appreciated, I'm sorry to tell you that. So whenever I have a patient that has been very depressed and suicidal, and suddenly they're telling me how great I am, it sets off an alarm in my brain, because I worry that that they're going to attempt suicide, and they're already kind of feeling some guilt that they know it's going to traumatize me, and they're feeling bad about that, and they're trying to help me with that before they do it. And so that's a concern whenever a patient is giving me effusive praise, which is very, very, very rare. Sometimes, since I work with adolescents currently, parents will, because they recognize that you're doing a good job, but patients generally don't. All right, and then going and buying a gun, that's one of the reasons why to buy a gun in California, there's a waiting period. That's why it's a bad thing that some of these, there's ways around that with these gun shows and things. But generally, you have to have a waiting period. You can't have had a 5150 in the last, I think it's 5 years. Those laws were put in for a reason. Anyway, just feeling hopeless. Like we've said before, chronic illness and chronic pain, being disfigured. We've had suicides of people that are very much, their ego is concerned with how they look or their job maybe, and because something happened, the car accident or some kind of problem, they kill themselves. And then, we've talked a lot about substance abuse and mental illness. All right, so when should you do a suicide assessment? Remember, the change of shift is the most dangerous time on a psychiatric unit. And so patients generally are aware that the staff that's leaving the shift, they're distracted because they're trying to get all their work done before they leave. And the staff that's coming on to replace them, they're hearing a report, they're not, and when they come on the unit, they're usually not fully present. Um, Although at Herrick we try to train our staff to go around first of all, at the very start, and just check on your patients. And we have a customer service question we ask them that training I got years ago that I still do is I'll introduce myself to the patient, and then I'll say, is there anything I can help you with right now? That's a basic generic question, but generally, I can gauge even by their body language, if they seem like somebody that's not in a good place. They could be suicidal or provocative, or looking to. The other thing we worry about at change of shift is that when patients know they're not being watched closely, that's when they might try to assault another patient, either physically or sexually. So that's when that can happen. And then there's something about the sleep cycle where you're isolated. There's not a lot of distractions. Trying to fall asleep, the problems going through your mind. There's not like groups and the other patients and the milieu and the TV or whatever else is going on the unit to distract you, and you're just kind of there with your thoughts. And you're usually not being watched as closely because you're in your room. And so that can be a dangerous time for a suicide attempt. All right, so just some basic things. The way to ask the question, and this has been the Sean Christopher Shea people, they say that they've done a lot of research on exactly how to ask this question. Have you been having thoughts of killing yourself? That's the exact verbiage they want you to use. And even though it's not really proper English, those English majors out there, have you been having, it kind of covers like right now and the recent time period. And thoughts of killing yourself, we want to say thoughts of killing yourself because committing suicide, that's a loaded term. So killing yourself is a loaded term also, but you're more likely to get an honest response because usually when somebody's having thoughts of killing themselves, that's exactly what they're thinking. I'm going to kill myself. I want to kill myself. They're not thinking I want to commit suicide. I can't exactly explain that, but I think part of it is whenever there's emotions around committing, when you commit something, it's usually a bad thing. You commit suicide, or you commit adultery, or you commit a crime, or and so it's harder to admit to thinking about committing something than to just killing yourself. But the killing yourself, you're more likely to get an honest answer if they are thinking about killing themselves, because that's what people think is, I'm going to kill myself. So when it matches what they're thinking, you're more likely to get them to be honest about it. All right, so you can also use the scaling question that we talked about a few slides ago, from 1 low to 10 high, just like a pain scale. How would you do it? Do you have the means? And on an inpatient unit, you want to be even more particular. On a psychiatric unit, we've gone to great lengths to try to make it where it's very hard to try to hang yourself, what we call a ligature risk. We try to eliminate those from the unit, especially the bedrooms and the bathrooms. But you really want to ask a patient, have you been looking for a way to try to kill yourself on the unit? And if the patient says yes, then that's your huge red flag that you need to have that patient on a one-to-one. Because even though we put a lot of money and effort, and there's companies that make special beds and special doors for the bathroom and special everything, so there's no ligature risk. You still don't know that a patient can't find a way to kill themselves on the unit. So if they're having that feeling and they're actually actively looking for a way to kill themselves on your unit, you better get them a one-to-one staff to watch them. All right, so then you ask them, can they agree? Let's say they're not looking for a way, or they were earlier, but they're not now. Can you agree that if it changes and you are looking for a way to kill yourself on the unit, can you come and tell a staff member? And you don't want to say, just tell me, because you might be on a break. It might be the next shift when you're gone. You want it to be, can you come and talk to a staff member if you start feeling like you're going to act on these suicidal feelings? Can you do that? And that's what we would call contracting for no self-harm. It's a verbal contract, and we're going to talk about suicide contracts a little bit later. So just to know, the verbal suicide contract with you, it only is as meaningful as their connection with you. And so they have to feel like they have a connection to you to feel like that they would need to obey that, to honor that no harm contract. It's only if they care about you, their connection to you. And so that can get a little tricky. You worry about patients that are manipulative, but generally what I've found, unless they have a personality disorder or I have no connection with them, really the connection is what they generally want to honor that. They don't want to end their life being a liar, basically, for most people. All right, so like I said on the previous slide, you want to use the phrase killing yourself. It sounds dramatic, but killing yourself is a dramatic thing to do. Committing suicide doesn't get you that phrase doesn't get you the same honest responses. And some people will feel uncomfortable and say, do you feel like hurting yourself? But that's different. The feeling like hurting yourself can be just the non-lethal, they feel like wanting to scratch on themselves, because it kind of, for some people, cutting on themselves or injuring themselves causes them to feel better. It's a coping mechanism. It's a dysfunctional coping mechanism, but it is a coping mechanism, and it causes a little release of euphoria for most people. And that's not what we are talking about when we are trying to assess if a person is suicidal. Right, suicide rating scales. So there's a lot of them. I'll cover the ones by the major organizations in our area. The SAD person scale is used by Kaiser, and some of the limitations of that one are it doesn't, we've had a patient before, and this was somebody that somebody I know at Kaiser had, that she was postpartum and she had a delusion that she needed to kill herself. Another, her baby had some kind of stomach problem and a lot of pain and was in the NICU, and she had a delusion that she needed to kill herself in order for the baby to be okay. And so that's a very high risk person. That's a very high risk delusion. But just going strictly by the SAD person scale, she only scored like a 2 or a 3, which had the recommendation of sending her for, outpatient follow-up care. So you don't just, a suicide rating scale is not a substitute for a suicide assessment. It can be good because, it can help flag a patient as being more suicidal than you may have known, or it might be a good screening instrument. But like you see on the slide, you're never going to make a clinical decision just based on a suicide rating scale. That's a very easy thing to manipulate, and you don't want to do that. This Columbia Suicide Severity Rating Scale kind of has more of it's looking at what's going on now along with aborted attempts and suicide attempts in lifetime. So it's a broader view than the Sad Person Scale. I would say at Herrick, we've put it into flow sheets that doesn't quite, it doesn't quite work that great in the flow sheet the way it was adapted, but it is a very, very, it's an excellent instrument for assessing someone's suicidality, but it's not a replacement for an interview. It's not a suicide assessment in itself. All right, so looking at care planning, our short-term goal, of course, that they're not going to kill themselves, especially, but also that they're not going to harm themselves, and they're going to be okay. And then our long-term goals, that an important long-term goal for somebody, especially somebody that's chronically suicidal, we're not looking at that they're never going to be suicidal again. That's considered not a realistic goal. Our goal is that they'll learn coping skills for their suicidal feelings. And in the future when they're feeling suicidal, they'll use their coping skills. And so one of the ways identifying what triggers you as well. And so like I said earlier, sometimes patients have chronic feelings of suicide. Sometimes the person is discharged and they still have active suicidal feelings, and it's because they feel suicidal all the time, and we don't keep people in the hospital for years and years anymore for suicidal feelings. It's considered if somebody's chronically suicidal, they're and that's how they always are, that they're at their baseline, as odd as that sounds, but they need outpatient treatment. They need, problem solving skills and learning how to cope with their feelings. Okay, so just some basic interventions. Sometimes to identify triggers, we'll give them a journal, and they can journal about all of the times, and especially what led up to their suicide attempt. That's a good way to identify triggers. We consider thoughts about suicide ideation to be just not a good coping skill. So that's why developing coping skills is such an important intervention. And if you're looking at coping skills, it's really important that it's specific. When you work with a patient for that, they need to have something specific to do. It can't be when they're suicidal again that now they figure out what their coping skill is. No, they need to figure out what their coping skills are going to be when their mood is at a level where they can actually, kind of learn and work on it. Not at the last minute when they're suddenly hopelessly suicidal again. So all of these are, cognitive interventions, which we talk about using an automatic thought record type of journal. Exercise is a big one. Remember, there's a release of endorphins, especially if you exercise longer than 30 minutes, especially, at least in my experience, around the 45-minute time is when the endorphins are really flowing. And so if they can do some kind of extended cardiovascular exercise, even if just going for a walk, that can work for people too, especially if they're not in good condition. All right, and then are they feeling hopeless and they just don't know what else to do, or do they really want to be dead? There are people that are kind of fascinated with the idea of being dead, and so that's more of a concern than the people that just are feeling hopeless and they can't figure out what to do. They don't necessarily want to be dead, they just don't know what to do to make their life better. All right, so other interventions, a safety plan, asking them about their plans for the future and try to get them to be as specific as possible. When you can have a specific plan for the future, even if it doesn't even work out, there's an expectation that they're going to be there in the future. And so we monitor them. We try to have the least restrictive means of monitoring. So that the common one for just an average psychiatric patient is to be checked on every 15 minutes. That can be increased to something we recently started at Herrick where they can be on 5-minute checks where they have to be checked on every 5 minutes, to line of sight where that would be a patient that you feel like is going to be cooperative with it. That's the number one thing about being line of sight. They have to sit where we can see them, but they also have to agree to be on line of sight. You know, we can't worry that they're going to sneak off and make a suicide attempt. And then to having a one-to-one staff where there's one person that's just with them all the time. And then, you know, we've had patients that attempted suicide even while they're on a one-to-one. And so sometimes a patient will need to be restrained to protect them from themselves. All right, so other interventions, make sure there's nothing unsafe in the milieu. Sometimes at Herrick, we'll have these little golf pencils that patients can use to chart on, or to journal, or write things down. And if you have somebody that's really highly suicidal and unpredictable, or violent and unpredictable on the unit, we have to take those off the milieu. Generally, with a golf pencil, you figure if somebody does try to stab themselves or someone else, it's very short, and they're usually not very sharp. At least we try not to have them be very sharp, so they wouldn't do a lot of damage. And it gives the patients a way to journal, which is an important technique for helping people, help themselves. If they have guns in their house or weapons, knives that they've stored, getting that out of the home. Sometimes we have to call the police if we know they have a firearm at home. One of the things about being on a 5150 is you can't own a firearm if you've been danger to self or danger to others for 5 years. There is a hearing you can go to try to make an argument later on why you would be safe with a firearm, but you're not allowed to own one. So, it's better if a family member that you feel is responsible will take the firearm away, and then it can be sold or give it to another, somebody that would be safe with it. But if you don't have that option, you can always let the police know as well. We can help them if uncontrolled pain or insomnia is one of the problems. We help them with that. Get them to go to groups and discourage them from being isolated. Back in the days before our beds were bolted down, we used to have an occupational therapist he was on the older person unit. He would go, and if a patient was avoiding groups, he would unlock their bed and bring the whole bed with the patient in it to the group. And so generally patients after that, it's embarrassing, so they would come to group after that. Yeah, and that's one of the things, especially with older people, they'll want to just stay in bed, and you can't let them do that. That's a big part of their illness, is the isolation. All right, and then at discharge, we give them crisis numbers, different crisis hotlines. There's even a text hotline now that's, I think it's 741 741, something like that. And it's for people these days, a lot of people, myself included, are more comfortable texting than talking on the phone, which seems like a lot more work, but I don't know, for some reason, I feel like you can be a little more personal when you're texting because a little more anonymous. I don't know quite what's behind that, but we're more of a texting culture than talking on the phone culture these days, especially with younger people. All right, we have our 3 biological treatments that research consistently shows is effective in reducing suicidal feelings. And this is research that all of the psychiatrists have read because it's a big thing out in the field. And so what you'll see if patients are, there's some patients that they're very suicidal. It's a constant thing for them that they're suicidal. And so with somebody that's got a mood disorder, either depression or bipolar disorder, you'll see eventually the doctors will try lithium. If it's a psychotic disorder, they'll try Clozaril. And, if it's just especially severe depression and it's available in the area, electroconvulsive therapy. And so you'll continuously see this over and over again. I've even seen people as young as 16 getting ECT. Just because it's such an established fact that these are the most effective treatments for suicidality. All right, so with our medications, there's some medications that actually can increase suicidal feelings. What you wouldn't actually think about it, but some of our most common antidepressants, our most popular category, selective serotonin reuptake inhibitors, can actually increase suicidal feelings, and that usually happens at about the 3-week period. And there's a lot of different theories about why that is. Some of the thoughts are that sometimes people are just too depressed to make a suicide attempt, and so SSRIs, they don't start to work until about 2 weeks, and then they don't start to work fully until you've been on it for about 4 weeks, and sometimes it can be longer depending on how slowly the doctor titrated up your dose. And so about the 3-week period is where there's considered to be an increased risk for a suicide attempt. And that's because at that time they're feeling better, but they're not well, and they now have enough energy to make a suicide attempt. So we also have these other meds, the Parkinson med, the acne med, Accutane, Parkinson med, Simitrel. Accutane it's a very effective acne med. That's why it's still used. You always know a med that has a serious side effects. If it's still being used, it's very effective. But it's along with causing suicidal feelings, it can also cause birth defects in pregnant women, and so in the baby, of course, and that's why most doctors, if you want to be on Accutane, you also have to show that you're on contraceptives. So our other one, Dilantin, probably our most famous medication for people that have seizure issues, also can increase suicidal feelings, along with our one ADHD medication that's not a stimulant, that's actually FDA approved for ADHD, is Strattera, and you have suicidal worries with that one as well. All right, so suicide contracts, no suicide contracts. They're like I said, they're only as strong as the therapeutic relationship. If they don't care about you, your contract with them, it doesn't mean much to them. But if you do have a strong rapport with a patient, and they've worked with you a while, or even if they haven't worked with you a while, if you feel like you've really connected with them, it's a lot easier to trust them when they say they're not, that they're feeling suicidal, but they'll agree they're not going to act on those feelings without coming and telling someone. And so no suicide contracts, they only work as a deterrent. They only help them not make a suicide attempt if the person feels connected to you. As an assessment tool, they're valuable though, because they, if a patient can't agree that they won't come to you before acting on their suicidal feelings, if they can't contract for no self-harm, that's a big red flag, and you need to raise their observation level, maybe even to a 1-to-1. And so that's very important for that reason. And then when we get into the suicide assessment techniques, we'll in the lab that goes along with this lecture, we'll talk about nonverbal leakage of intent. And what that means, if they're not being honest with you, they'll break eye contact, and they'll hesitate. They won't answer right away. Most people that are not used to being manipulative, that are just normal people, there's a definite tell when they're lying to you, especially about something important. And so that's what we look for. It doesn't mean you'll automatically think that they're not, that they're lying to you. It just means you'll take a break and sit down and assess them more thoroughly. All right, legal issues when a patient commits suicide. And I'm talking about when a patient commits suicide either on your unit or within 72 hours of being discharged from your unit. That's considered the time frame that we're responsible for them after they are discharged from our unit. It's always a very emotional issue when this happens. If you work in psychiatry and you have a long career, if you work in acute psychiatry, this is eventually going to touch you. And there's no way to quantify how many people you actually save, but eventually a patient is going to kill themselves. And it's very hard psychologically. Your staff struggle with feeling responsible, and there's always this kind of issue where, especially if they suicide on your unit, there's going to be it's called a CMS, comes and does a evaluation, and that's basically the state. And if the family files a lawsuit against the hospital, you're going to have to, well, first of all, before we talk about any kind of lawsuit, what happens when this or any really serious unexpected event happens in a hospital? There's something called a root cause analysis. And if you're ever part of an issue, where you're working, where it was either you were the charge nurse or that was your patient, or even if you were on the unit and this wasn't your patient, you'll probably be involved in the interviews with risk management and the kind of lawyer type of people in your hospital system. Generally, there'll be what's called a root cause analysis. And what you have to do is make sure you attend all of these type of meetings, because if you're not there, there's nobody to protect you. You need to come and defend your actions. And the root cause analysis, if you don't go, you don't know that you're not going to end up being these kind of head honchos of the hospital are going to decide you're the root cause analysis. And so it's common for when this kind of thing happens, people think, well, I'll take some time off, but you can't take time off. You need to come and defend yourself. Hopefully this will never happen to you, but if you, like I said at the start of this slide, if you work in psychiatry for a long time, eventually you're either going to have a patient suicide on the unit or shortly after discharge. And if after the discharge is within 72 hours, then it's considered the hospital's responsibility. And you have a root cause analysis then also. All right, so legally, so there's three categories of legal liability, and these all look differently. First of all, if the patient wasn't assessed as a high suicide risk, that's what number one is referring to. Then number two, if you did assess them correctly, or whoever the nurse was assesses them correctly, but then you didn't order the correct things, your patient says they are looking for ways to kill themselves on the unit, and then you don't put them on a one-to-one, that would be number two, where you didn't do what would be considered the reasonable treatment in the field to protect that patient. And then number three, you did assess them as a high risk. You did get the order for the one-to-one, and whoever was watching that patient didn't watch them closely enough. I'll just give you an example of what that can look like. We had a patient who, she was a very high-functioning woman, and she had been placed on a one-to-one for being suicidal. And then overnight, and this was a very kind of classy person, and she had kind of minimized it to the one-to-one, and it was shift change between night shift and day shift. And I was coming in as a day shift charge nurse on an adult psychiatric unit, and I was listening to a report when we heard a big crash. And what had happened was the one-to-one had let the woman use the bathroom unsupervised. So she was outside the door, but and the woman was in the bathroom for a long time, but the one-to-one staff, who was an LVN, didn't check on her. She trusted her that she was, safe in there. And what was actually happening in there, the woman had snuck in a razor blade in her hair. So it got through the metal detector wanding that we do when they come in. And she was cutting up the shower curtain and making a noose out of it. The shower curtains on a psychiatric unit, they're not like a shower curtain that you would buy for your home. They're specially made where you can't tear them, but they're assuming you don't have a razor blade in the hospital. And so anyway, what the woman had done was she made a noose out of this shower curtain by cutting it into strips and tying them together, which you think would have made some noise that the one-to-one would have checked on. And then there was a inverted sprinkler, for the fire alarm in the bathroom, and the patient tried to hook her noose onto the sprinkler and hang herself. And what happened is that the way we have the sprinklers inverted, it didn't catch, and so she crashed to the floor. And so we came out, and that had happened. That's kind of how I started my shift one Saturday on 4 East Day, if you know what that means, years ago. And so that patient, and she wouldn't talk to me after, since I was coming out as charge nurse anyway. I took over the situation, and since she was suicidal with a one-to-one, even on a one-to-one, she was able to attempt suicide. I put her in seclusion and restraint to keep her safe. And the person who was the one-to-one got in a lot of trouble because she, number 3 here, she failed to carry out the treatment. She didn't watch the patient like you need to watch it, somebody that's on a one-to-one. And this was a classical case of it being shift change also, that LVN, she'd been with this person, she'd been directable and cooperative all night, and the LVN who had a lot of experience, she wasn't like a new person. She, it was shift change. She was starting to get in the mindset of going home and going to bed after that. She was at the end of a night shift. And so, that's how things happen. That's what number 3 looks like. That number 1, we assessed her as high risk. Number 2, we got the one-to-one, and then the one-to-one failed. And so that would be category number 3. All right, so what we have when a suicide happens and the family is suing the hospital, one of the dynamics that happens, when it's very painful when someone in your family commits suicide. And so there's a lot of guilt, there's a lot of blaming themselves and blaming each other. And what is a healthy defense mechanism for the family is what we call the wounded family dynamic, where they kind of join together and sue us. And so that's just something to know how that all comes about. So once a family hires a lawyer, they usually hire these lawyers that work just for usually a very high percentage of the settlement that they expect. And so if you're a lawyer, personal injury lawyer like this, where and sometimes from what I understand, the lawyer gets like 65% of the settlement in these cases, but the family doesn't have to pay anything to retain them. So what that means for the lawyer is that it can be devastating to their law firm if they take on a case and put a lot of hours into it and they don't get a settlement, or the lawsuit goes to trial, civil court, and they're awarded a large settlement or a large cash award. And so what lawyers will do before they make a final decision to take a case or not, they subpoena the records and they look at all the documentation. It's been compared to taking over a chess game. You have a choice of like 10 chess games to take over, and what you want to look at is the chess game that you think you're most likely to win. And the way you choose the ones you would have the best chance to win is by looking at the documentation of the staff, of the nurses, of the doctors, and that's where you get the idea of which one you want to pick up. And so it's it sounds bad that this is like a game, but this is, it's the world of lawyers. But it doesn't mean that your documentation will necessarily make it where nobody will ever pick up the case, but probably the best lawyers, the ones that look at it, they're not going to choose your case if your documentation is very good. And they don't want to take a chance that they're not going to get a settlement. I was involved in a case at Herrick where a family did this and it got thrown out of court, and so the lawyers involved didn't make any money from it, and they wasted all of their hours. So anyway, the bottom line is your documentation is your best defense. So one of the things to know, and this is really important if you're going to work in psych, that you know that you don't let this devastate you if this happens. Remember, we save 99.9% of the people that come in. You're not going to, you know, if you have a long career, you're not going to save everyone, and that's just the reality. Um, Now, what you're responsible for, like you see on the slide here, is to know how to do a real good suicide assessment and detect risk when the risk is elevated. You're not always going to be correct. That's not realistic. Patients can and do conceal their intent to suicide if they are, if you know, if they're 100% decided they want to do it, they can conceal it. Um, all of our suicide assessment techniques that you're going to learn in the skills lab, they really kind of rely on a little ambiguity. That's kind of our in, that we can get that little part of them that still wants to live to listen. And so, you know, and respond to our techniques. But that's not always the case. And and just an aside, some of the people that have kind of gotten bias where I work is are people that actually work in, you know, they were, I'm thinking of two people in particular, but they were mental health professionals. They when I don't want to go into specifics on the recording, but they had their own kind of training in psychiatric skills, and so they were even better at concealing their intent than just an everyday person. So, like I say in the slide, despite everything I'm going to teach you in the skills lab, it's not always possible. You're not always going to detect their suicidality. All right, so the documentation, how does good documentation look? Um, so when you're documenting the your suicide assessment, you're going to say what the risk factors are. You can include demographics that we talked about at the start of this presentation that are, you know, specific to the patient, and then any, you know, the details of their suicide ideation, including their plan and intent, and then what is your professional opinion? And so this is why we get paid what we get paid, to make these kind of assessments, not just for suicide, but for other parts of nursing as well. But um, you have to state your reasoning and and you know, give a clear idea of why you think this patient is safe to go home. You can cite the protective factors that we talked about earlier. Um, you know, anything like that is very helpful. All right, I can't train you in suicide assessment without talking about borderline personality disorder. The techniques that I'm going to teach you in the skills lab, um, this is the population where you're not going to use them. That this is the person that you steer away from talking about suicide because they move in and out of it so easily. Now, the person with this disorder, and when we say a personality disorder, it's kind of the fundamental structure of their personality has an issue, and so it's not a clinical syndrome. It's part of who they are, and so these people feel very empty inside, and this picture kind of sums it up here, where you feel kind of naked and exposed and vulnerable, and abandoned easily. And my guess in this photo, it's supposed to be that she's cut herself and written in blood on the wall her feelings. Um, I've seen this many times with borderline personality type of patients where they'll cut themselves, and they will write these kind of things on the wall if they're, especially if they're angry at the staff. Um, they'll cut angry words about themselves on their body if they feel like they're overweight and they don't like their thighs, they'll cut fat. You know, they'll cut the word fat on their thighs or on their abdomen, and they'll cut it so deep that there's an actual scar. So common features of personality disorders in general, they're deeply ingrained. They don't change very easy. They don't do well inpatient. The preferred type of therapy is long-term outpatient therapy. Um, Trouble in all of their relationships. They're people that get too close too fast, but then they don't have boundaries. They have their problems are almost always in relationships, whether the relationships are their romantic relationships, their relationships at work. Um, Starts at their adolescence, and they can't handle any kind of stress or pressure. They don't know, they don't have insight. Um, they don't realize it's them, even though there's a pattern in their relationships where they all fall apart. It's always the other person's fault. No boundaries, and this causes a lot of conflicts. And when we say black-white relationships, we mean they see people as either all good or all bad. You're either with me or against me. When we say splitting, that's what we mean. Is they'll a typical thing is and they're very very manipulative. They'll if you're doing something nice for them, they'll do everything they can to make you feel like you're the greatest nurse ever, until you have to set a limit with them, or you can't give them something that they want. Then they might fall apart, and they might see you as the worst nurse, the worst person, and that's what we call splitting. They see you as either all good or all bad. They don't have any shades of gray in there. They are very manipulative, and one of the basic things with a manipulative patient for your treatment planning when you have a patient like this is you always refer them to their nurse. Any patient that has a problem with manipulation, and borderline personality patients fall into that category, along with another personality disorder called antisocial personality, which we'll talk about in a different lecture. But they're very manipulative, and part of the plan at the start of the shift is all requests have to go through their nurse. So diagnostic criteria, they are frantic to avoid any feeling of abandonment. And the feelings of abandonment are so intense in their outpatient therapies. One of the things borderline personality disorder patients are famous for is when their therapist goes on vacation, they make a serious suicide attempt right before the therapist leaves because they're so threatened by the feeling of being abandoned by their therapist. These are the people that if you try to break up with them or leave the relationship, they try to kill themselves or do something that draws you in, makes you have to pay attention to them. I've seen it be as intense as a woman whose husband was a firefighter was trying to break it off with her. So, and he was a firefighter in their area, their same town. She set the house on fire. because she knew he and all his coworkers would have to come and put it out. And, the whole house burnt down. So that's kind of an extreme, but that just shows how how dramatic it is when somebody with this disorder feels like they're being abandoned. Um, Another thing about them, they don't have a consistent image of themselves, and so it's always kind of shifting, and that's another reason that they don't have a center. They don't feel centered at all. So they're impulsive, and this can be sexually acting out. It can be binge eating. Um, People with borderline personality, they're more likely to be overweight because that's like a way of trying to feel that emptiness inside is overeating. They'll intentionally put their life in danger with reckless driving, spending too much, all of that. And then a big thing with borderline personality is they move in and out of suicidality very easily. So there's a lot of cutting. There's a lot of suicide attempts usually in their life. Um, and just, they'll have scars all over the place if there's somebody that's very seriously borderline. All right, so very emotionally reactive. They overreact to a lot of things. They're very intense, very exhausting to be in a relationship with. Um, like I said earlier, chronic feelings of emptiness, this anger that can come out of nowhere that's so very intense. And they can even have dissociative symptoms, even to the point where sometimes they believe they have dissociative identity disorder, what used to be called multiple personality disorder. But it's part of their diagnosis to have dissociative type of problems as well. So in working with a patient with borderline personality disorder, first of all, we try to teach them some stress reduction techniques. Teach them about substance abuse and if that's one of their issues. If they cut themselves, and when they cut themselves, it's at a time that's usually very inconvenient for you. Um, I remember a young woman that was my patient. She managed to get a razor out of, where I don't know why we had razors where they could shave their legs, but they had them. We usually don't worry about that on a psych unit, but she managed to get a hold of a razor and she cut her thigh fairly seriously enough where needed to address it. I needed to take care for it, and she did it right at 3 o'clock when I didn't have time. And what you what's critically important is that when they cut themselves, you don't want to give them that emotional reaction. You have to take care of it, but you want to do it in a matter-of-fact way. You don't want to do it in a way that gives them like an emotional reward, or the untrained person will be like, "Why did you cut yourself? You have so much to live for," and all this kind of stuff. You don't want to do that. That makes it more likely they'll cut on themselves again. What you want to do is try to stay emotionally neutral and take care of it in a matter-of-fact way. Not always easy. We're human beings also, and the patient I was referring to that was right at when I need to go tape report for shift change. Um, and so that, it's not always easy to do it. They're very good at doing it at times when they make you pay attention to them, when, they're perceiving that you're about to abandon them. And for that patient, even though I didn't feel like I had a strong connection with her or she had an attachment to me, still the fact that I was going to be leaving, giving a report to the next shift, that was enough for her to try to make me have to be involved with her more. All right, and then just our basic anger management techniques. All right, so I have this for you. people that like your concept map kind of things. And I'll let you look at that on your own. There's a lot, and we're going to talk about borderline personality again when we have our personality disorders lecture, but you can look at this on your own. So how is suicide assessment different with somebody with borderline personality disorder? Well, we're not going to ask them the suicide question that I taught you. We're not going to say, have you been having thoughts of killing yourself? Because this is the patient that wants your attention so desperately that they're going to go there. They're going to not only say that they're having suicidal feelings, they're going to have suicidal feelings to get you more connected to them, because that's what they're desperate for. And so we don't ask them that question. We try to get them to focus on their coping skills and away from what we call suicide talk. We want them and generally somebody, especially if we know that they have borderline personality disorder, they've been through a lot of therapy. So when you get them to talk about coping skills, um, generally they have an idea of what you're talking about if they've been through therapy, which most, like I said, most of them have been through therapy a lot. And so get them talking about how to cope with things, and don't reinforce suicidal talk, because this is the patient that will become more suicidal the more you ask them about it. Most of the time, that is not the case. That is not the case with regular patients. Regular patients, you need to ask them about suicide. You need to cover it. If you don't ask them about it, they'll think you're incompetent, and you are incompetent if they came in because they were suicidal and you don't ask them about it. But with the borderline personality disorder patient, this is why if you've been a student on a psychiatric unit, and you may have overheard when they're talking about a patient that you can talk to, usually the patients that they don't want students to talk to are the patients that have either borderline personality or borderline personality traits. And so they know that you don't have the experience to talk to that patient, and that you talking to them, if you let the patient get you to talk about suicide, could lead to that patient becoming suicide and acting out, becoming suicidal. So that's why you'll hear, keep the students away from this patient. That's why it's usually a patient that has borderline personality disorder. All right, so this most and there probably are people in this class that have a stuffed animal in your room, and it might be something that's just a decoration. It might be a leftover thing from when you were younger. But if you were ever hospitalized for anything, you're, if you don't have a borderline personality disorder, you don't bring the stuffed animal in with you to the hospital as a grown-up. But patients with borderline personality do this kind of thing. If you see a patient coming in that's a full-grown person, and they're not they're not developmentally delayed or anything like that. And patients with borderline personality in general, they're very smart, very high-functioning people, and sometimes very, very accomplished in their career. But if you see an adult that doesn't have a developmental disability, and they've got a large teddy bear like you see on the slide here, and holding on to it, that's almost always somebody with borderline personality. There's something about it that they regress. They become very childlike, especially in the hospital. It's normal. People do tend to regress a little bit in the hospital. Part of it is you're sick, and part of it is, there's always people trying to take care of you. um, but not like the patient with borderline personality. They really regress, and that's why we try to get them out of the hospital as soon as possible, because they don't do well in the hospital. All right, so our other big category that we need to look at are patients with psychosis. And remember, patients that have their first psychotic break when they're schizophrenic, um, there's frequently a very serious suicide attempt that comes with that. Um, the kind of things we worry about is number one, command auditory hallucinations, you know, and remember you have to ask them what are the hallucinations telling you. And the big thing, if the voices are telling them to kill themselves or to harm someone else for that matter, you need to ask the patient the follow-up question, do you feel like you have to do what the voice tells you to do? Is it the voice of God telling you to do it? Or is it just an annoying little thing that pops up from time to time that you ignore and you would never follow the crazy things that it tells you to do? Um, so it can be very dangerous if the patient does not feel they can say no to whatever the voice is commanding them to do, obviously. Another big concern with psychotic patients is feeling like they're not in control of themselves, that they're being controlled by some outside or alien force. And so the patient might say, "Yeah, I can agree. I'm not going to try to kill myself or hurt anyone else, but I'm not really in charge. I'm not in control of myself." Then the third one is some patients they feel like they well they get very religiously preoccupied, and they might feel like they need to sacrifice themselves, like Jesus Christ had to sacrifice his life for the sinners, in the Christian religion. Um, and this can be very very dramatic. It can be something like they try to cut off their penis, or because sometimes they have a lot of guilt around their sexual feelings. Remember, especially for male patients, their first break for a schizophrenic, their first psychotic break is usually between ages 15 and like 22, 25. Um, for females, it's a little older. It's like usually like maybe, I don't know, 18, 19 to 28, 29. That's a ballpark figure, but females is a little older. But remember what's happening to the teenage male at those years is they're emerging, very high sex drive. And so, along with the religious preoccupation, there can be a lot of guilt around those feelings. Um, and just a note, the most patients who do successfully end up, that are schizophrenic that kill themselves, they do so in the maintenance phase. Even though that very first break is a very dangerous time for a serious suicide attempt, in the long run, they kill themselves because of the hopelessness of having this chronic, severely disabling illness. When they're relatively stable, and you'll remember from the lectures on our psychiatric medications that the medications that work for psychosis, they restrict your dopamine, they restrict your serotonin if we're talking about the second generation or atypical antipsychotics. And so those are the ones that make you feel good. And so it's hard to not only have that challenge, but also know that you're really never going to be better. And there's really no hope. The best you can do is, help, you know, control these symptoms the best you can. And, sometimes it's a very sad life. All right, so just a few test questions here. Patient tells the nurse, quote, "The stresses in my life are overwhelming. I have no option but to kill myself," unquote. The nurse's best response: A, initiate a one-to-one observation order. B, give the patient the ordered PRN Ativan. C, ask, "Tell me about your stressors." Or D, give the patient the crisis unit phone number. So I'm going to give the answer now. If you want to think about this for a second, go ahead and pause the video. Now, the correct answer here, and part of what's frustrating in nursing school tests, is that this doesn't tell you, is the patient on an inpatient unit? Is this an outpatient clinic? But what you would want to do, the patient has already brought up their stresses in their life are overwhelming. What you want to do is explore that further and ask them about the stressors. Now, you might want to also, if you're inpatient, you might want to get them on a one-to-one. If after interviewing them, you do feel like they're a risk for attempting suicide on the unit, you definitely might want to give them the ordered PRN Ativan, which is a very common medication we give out on psychiatric units to help people stay calm. And if you're, if they're on an outpatient type of setting and you don't think they need to be, you don't think you have to go to all the effort to put them on a 5150 and get them hospitalized for their safety, you can give them a crisis unit number. But one of the things I want you to remember with D on nursing exams and on the NCLEX is the answer is almost never to put it off on someone else. And so, D is kind of has that flavor of giving them a crisis number. That's not usually going to be your answer. All right, so a patient tells the nurse at the outpatient clinic that his plan is to jump off the Bay Bridge at 4 a.m. The nurse's initial response is A, offer medication, B, give the patient a journal and a pen, C, ask the patient about stressors, D, discuss alternative coping methods, E, call 911 to initiate a 5150 danger to self. And so I'm going to talk about this and give you the answer. Again, if you want to think about this, go ahead and pause the video right now. So as we look at this, so this patient's plan is very specific. They know that they have a bridge picked out. They have the time. And you do know in the question here that they're in an outpatient clinic. And so if this patient is thinking about doing this and they're talking about tonight or this, tomorrow morning, early morning, the correct answer would be to call 911 and initiate a 5150 danger to self. The EMTs generally come and the police will come and they'll evaluate the patient. The police do have 5150 privileges, at least the ones that respond to this kind of call, they always do. There'll be EMTs that transport the patient usually to an emergency room to be medically cleared to go into the psychiatric unit. Yeah, so E would be your correct answer. And these other ones that they don't take it seriously enough for a patient that has a lethal plan. Jumping off a bridge is a lethal plan. And they've already chosen the bridge, and they even have chosen the time, which probably a patient that chooses 4 a.m., they're trying to be nice about it and not cause traffic on the bridge during the commute. Or they want it to be peaceful. They don't want the commute around them. All right. Right, so this lecture was one of the things that was very important for me um, was that this lecture is the best that I can do on this topic. And I consider this the most important topic of the things that I teach you. And most psychiatric nursing textbooks that I've looked at, they don't cover it quite enough. And so, putting together this lecture, I not only used psychiatric nursing type of resources, in your textbook, but, in my experience, but also these two professionals that I read these books and I took a lot of the content that you read here from these books. And I didn't read these books just for this lecture. I read them because it's the most important topic for me to be an expert in, to be the kind of psychiatric nurse that I want to be. And so it was a very emotional journey, and reading these books, they're both excellent. If you go into the field of psychiatric nursing, I highly recommend them. All right, so let's just take a brief look at the learning objectives now that we've gone through the lecture. So suicidal behavior is actual suicide attempt, doing things. I would consider something like tying a noose and loading a gun and hoarding pills, that kind of thing as well, where you're preparing for a serious suicide attempt, actually taking steps toward it. I would consider that suicidal behavior. And then suicidal ideation is thinking about it, thinking, you want to, but you're not actually taking steps yet. You're just kind of mulling it over. And then self-mutilation is usually cutting on yourself. Some people get relief from that. Most of the time, that's not something that's a huge priority on a unit. It's considered dysfunctional coping. It's something we want them to move away from. We don't want them to do it on the unit. And we don't want them doing it at all, but it's not as worrisome as the other two. So risk factors for suicide. So we talked about multiple of those. Having, just in general, there's the demographic ones, being a white male, over 65, that kind of thing. Having a gun in the house, having family members that have committed suicide, having a major psychiatric illness like major depression, bipolar disorder, or schizophrenia. And then protective factors, some of the biggest ones to think about, just off the top of my head, having an obligation to other people, that you either have children or other people that rely on you, or even your pets, believing that suicide is wrong, having religious beliefs that don't favor, don't give you a permission to commit suicide. Just some things like that. Other risks, just going back to number 2, other risk factors: uncontrolled pain, insomnia, and probably too many of them to identify here, but you'll want to be familiar with the ones on the slide, so that if you see them in a select all that apply question, you'll know the difference between these two. All right, so we talked about how to protect yourself legally with suicidal patients, and those different levels of responsibility and what you're expected to detect elevated risk. You're not expected to be perfect. And even in other settings, if you have suicidal patients, just because you're a med-surg nurse or a maternity nurse, you still have to address those. And especially if you work on a postpartum unit, you have to be aware that postpartum women are high risk for postpartum psychosis, postpartum depression, and the kind of tragedies that can come out of those situations. All right, the strengths and limitations of the suicide rating scales. Remember, a rating scale is not a substitution for an assessment. You need to interview the patient. You need to know how to do a suicide assessment, including, what we're going to talk about and what you're going to do with each other in the lab that accompanies this lecture. The how to, what we call nonverbal leakage of intent, how to spot that. That's what you're going to make your decisions based on, your actual assessment, not on suicide rating scales. So number 6, the no suicide contract sometimes can be written, but usually it's just verbal. And remember, it's only useful as a deterrent if the person has a connection with you. It's useful as an assessment tool because if they say they can't contract for no suicide, definitely you need to take action and put them on a higher level of observation. All right, number 7, how suicide assessment is different with a borderline personality patient. So it's different in the way that you steer them away from suicide talk, is what we call it. We don't ask them, have you been having thoughts of killing yourself? Because we know that they will move into that as a way of connecting with us because they're so chronically empty. They're desperate for connection, and they move in and out of suicidal feelings very easily. And if they feel like that's what gets your attention, they're going to move into that. So we get them to focus on coping skills. What coping skills have they learned in their therapy? And most patients that have borderline personality disorder have had a lot of therapy in their life. So 8, know the special considerations for assessing a psychotic patient for suicide. So we talked about that just a few slides ago, talking about command auditory hallucinations, belief that they have that they're not in control of themselves, that what we call a delusion that they're being controlled by outside forces or alien control. And number 3, a religious, many of them with psychosis, especially schizophrenia, they get religiously preoccupied in a very dangerous way, and believe they need to sacrifice themselves for the good of other people. And so just like Jesus in the Christian religion, they need to sacrifice themselves, and that can be very dangerous. Number 9, 3 biological treatments that research has shown to be the most effective in reducing suicidal feelings. By now, this is you've probably been exposed to this already if you remember. The 3 biological treatments are electroconvulsive therapy, lithium, and Clozaril. Those 3 treatments, far and away, research repeatedly has shown is the most effective way to treat patients that are chronically highly suicidal. All right, so number 10, 6 common medications that can increase suicidal feelings. And so, we have the whole category of the selective serotonin reuptake inhibitors, particularly at the 3-week period. We have Dilantin, one of the most popular anti-seizure medications. We have Strattera, a very common medication for ADHD, especially among parents that don't want their child taking a psychostimulant. We have Sematrel, that's an anti-Parkinson medication. And Accutane, that's a very, very popular medication for acne, and one that not only can increase suicidality, but can cause birth defects. And so you have to be very careful in giving that to a female in their childbearing years. Number 11, the 3 categories of legal liability when a patient suicides on an inpatient unit. So what we're referring to here, the 3 categories, the first one is that they weren't correctly assessed at the level of suicidality that they were. They weren't assessed correctly. Number 2, they were assessed correctly, but the correct level of observation was not ordered. And so you assess them as high risk, but then you didn't get them a one-to-one staff, or or even restrain them if they were really that suicidal. And then number 3, they were assessed as high risk. They got the correct order for a high risk patient, which is getting them on a one-to-one where they have one staff watching them. But then the treatment wasn't followed, that the one-to-one didn't watch them correctly enough, complete enough, and the patient killed themselves. And so those are the 3 categories that the law looks at when looking at a suicide. And then number 12, what was the conclusion of the research that showed no difference in the rate of suicide between Persian Gulf military veterans who had seen combat and those that didn't see combat? The conclusion was that since most veterans like to own a firearm, that their conclusion was it wasn't really seeing combat or not that made a former military veteran, be suicidal. It was just the fact that they were more likely than the average population to have a gun in their house, after all the training with guns. And so that is it for our objectives. And one thing to remember is that there will be exam questions that come from the suicide assessment techniques I'm going to teach you in the lab related to this lecture. And so you don't want to just learn the learning objectives here, because those are very important for your career and your short-term goals of doing well on the exam questions related to suicide. You'll want to take a lot of notes in the suicide assessment techniques skills lab that we're going to have following this lecture.